نبدأ. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. Welcome everybody in this new meeting of Egyptian Society of Nephrology and Transplantation, which is a really distinguished meeting. For this night, this is the first time of the season to have two speakers in one session, which is supposed to be a very hot session and very distinguished session. We have two speakers, Professor Hisham Said, Professor of Nephrology at Shams University, and Dr. Tarek Tantawy, Nephrology Consultant, which are all well known in their great expert in dialysis. This meeting will be moderated by another great professor and eminent star, which is Professor Muntasir Zaid, Professor of Nephrology and Internal Medicine, Alexandria University. So we have three experts in the field of hemodialysis to speak about hemodiafiltration in this hot session and distinguished night. Did we start? We will start by the two lectures sequentially and leave the discussion later on according to Professor Muntasir. Professor Muntasir, please take the mic and take the meeting.
Bismillah ar-Rahman ar-Rahim. It is a great pleasure and honor to have two eminent speakers, Professor Dr. Hisham Said, Professor of Nephrology at Shams University, and Professor Dr. Tarek Tantawy, Senior Consultant of Nephrology. They will talk about an old and at the same time new technique in hemodialysis, which is hemodiafiltration. Actually, patients managed with conventional hemodialysis and potentially expected to hemodynamic instability, excessive intradialytic weight gain, anemia, mineral and bone metabolism disorder, inadequate nutrition, infection, and sexual and psychological problems. I want to remember you with the hemo study, which was a randomized clinical trial, did not alter survival or morbidity by increasing dose of dialysis or using a high flux dialysis membranes. Actually, hemodiafiltration started since about maybe more than 40 years. It started since 1974, and it was at that time with replacement solution in plastic bags. For a long time, it was costly because of the cost of solutions, replacement solution. But as I remember, since about 20 years, I paid 20,000 Egyptian pounds to upgrade a machine, 4008 machine, to upgrade it to online hemodiafiltration. And we worked with this modality of treatment for many years. I think Professor Hisham Said and Professor Tarek Tantawy will give us what happened during these 20 years till now. I will give the mic to Professor Dr. Hisham Said to start our talk. Dr. Hisham, tfaddal.
Thank you very much. Good evening, all. Thank you, my colleagues, friends, and professors. I think it is a very special day. We have a great speaker, Dr. Tarek. We have a great moderator, Professor Muntasir, and we have as well great attendee and sharing us this very important topic. Today, I will just highlight some of the important issues in the techniques, following by Professor Tarek, who will advise on the indications and some of the randomized controlled trial on hemodiafiltration in the past years. So let us go directly To that, I want to share, if you allowed me to share screen, I will share with very short talk on the hemodiafiltration regarding the doses and the barriers. So hemodiafiltration meaning and doses, we need to know in this talk if the audience is still junior in this field of hemodiafiltration. You need to know the following: what is the definite technique, what is the modes, and what is the filtration fractions applied during hemodiafiltration, what is the barriers to achieve successful hemodiafiltration. Not all the sessions are the same. And finally, what about the hemodialysis and the hemodiafiltration machine with what's called a feedback control. So hemodiafiltration technique is the hottest and the loudest and very strong technique in hemodialysis, meaning that hemodiafiltration very fraction, removing about 25 liters from the patient with subsequent substitutions. This is a very burden on the dialysis membranes. So a very forceful convection volume and with an inline substitution or infusate from bags. The dragging forces to remove higher molecular weight from the blood side. So it depends here, unlike high flux dialysis, which is more smooth, we depend here on the transmembrane pressure to drag force on the dialysis membrane to remove larger molecules. Barriers for that is a lot, and we'll discuss later. And this carries both diffusion and convection on the same time, because hemodiafiltration, meaning there is an element of diffusion, while hemofiltration, meaning purely convection. If you combine that, it's called hemodiafiltration by diffusion and convection. Membrane operations in the molecular and separations and the elimination of uremic toxins take place by diffusive and convective transporting, resulting in high removal rates for both the middle molecules and larger molecules. Online hemodiafiltrations provide high removal rates over a wider molecular weight spectrum, even if you are using the same dialyzers, again, by the force of dragging and the force of higher transmembrane pressure. So convection, meaning that removal of excess water, subsequently carry with that excess water removal is the middle molecule. So this is a concept to remove water, including in that higher molecular weight proteins. On the expenses, for sure, for the tragedy on the dialysis membrane during the 4-hour session, as well in the albumin leak, and we will highlight that in the later slides. So what is the difference between high permeability or medium cutoff or what's called protein leaking dialysis membrane? Here the higher membrane permeability reaching up to 45 kilodalton, while hemodiafiltration can reach as well this category of toxins by the excess of the transmembrane pressure and the dragging forces. So both of them, meaning that removal of wider range of molecules, especially that including in the inflammatory process, cytokines and leptins, and the others are including in the both the medium cutoff and the hemodiafiltration techniques. So quantification is needed in medium cutoff, while hemodiafiltration doses are well prescribed nowadays for more than 10 years to reach the highest and the largest volume of substitutions available at the session. So hemodiafiltration using simply the same dialysis membrane, however, the dragging force is a maximum, and this needing transmembrane pressure, making the membrane after nearly 1 hour fouling by the proteins adsorbed. We have two elements here in the hemodiafiltration. what is called the hematocrit increasing inside the dialyzer, and the protocrit, it is not a common name, but it means the protein content of the blood. So removing excess water from the blood passing through the dialyzer, increasing the hematocrit very hugely, more than 50% increase in the hematocrit inside the dialyzer, as well concentration of protein inside the filter, making that too much effort inside the membrane, and subsequently it should be the hemodiafiltration machine with a feedback control to clean up the filter during the session and to minimize the increase of the transmembrane pressure to the highest level of danger, because rupture of the fiber can occur, protein clogging, clotting, all of that can happen, but the hemodiafiltration biofeedback control of the hemodialysis machine can control that automatically. We will highlight that the difference between hemodiafiltration automatic profile or manual profile. So randomized trials on different dialyzers showing that the difference between the lower diagram by high flux, even with the same dialyzer like Lucid, Polypure, Rex's, Vita E, the difference between the high flux reduction ratio for 3 light chain, for example, which is around 24,000 Dalton, meaning that if the same filter are using in high flux dialysis, when using such a filter in hemodiafiltration, the reduction ratio increase for such big molecules. So this is simply how it's applied and the difference in the clinical performance. On the same time, there is some tangential albumin loss that could exceed 3 grams per session in some dialyzers, and lowest, for example, Polypure S, but higher, for example, in polyether sulfone membrane that can reach the albumin loss in around 3 grams. Very interestingly, the albumin loss maximum is within the first 30 minutes before the protein clogging of the pores. So meaning that it means the membrane is kicked out by the blood, high hematocrit, high protocrit during the hemodiafiltration, and the cautions inside the filter integrity should be made. So the ultrafiltration between the dialyzer filter as well the substitutions take place around the dialyzer. If we put that the filtrate and the substitution post the filter, it's called post-dilutional. But if we put that pre-filter, it's called pre-dilutional. Both of them could be used with some indication for each of them. Importantly, before going to do hemodiafiltration, you have to check that around 30 liters are intravenously injected inside the patient. So pyrogens are not allowed. Bacteria is forbidden. Other impurities could not be used. So there is a quality control system to use hemodiafiltration in water purification system. You need 3 steps. 1, you have an ultra pure water. Second, you have an ultra filters or endotoxin filters. And this intra machine filter in the backup of the machine to remove in series, not in parallel, the dialysate, the final pathway of the dialysate. We have 2 systems here. We have what's called 2 barrier system, meaning that there is 2 endotoxin filters only, and this is typically for Fresenius machines. And we have what's called triple barrier system, meaning we have 2 endotoxin filters fixed inside the machine, and additional one which is disposable filter in the hemodiafiltration line, and is called triple barrier system. So we have 2 and 3 barrier system between different of them. Importantly, what I like exactly is to check regularly and routinely the endotoxin filter not exceeding 100 sessions of hemodiafiltration, may be lower. If you are using, for example, chlorine, as in this infection, the lifespan of the filter drops away, and maybe just 10 or sessions using chlorine, the endotoxin filter is not capable of removing the endotoxins and may be very porous. Taking account that the machine did not test for endotoxins, the machine tests for the porosity and tests for the pressure drop every 5 weeks or not. So we have to connect that carefully, and calculating that the machine automatically calculates that by 100 sessions, but never to use so frequent chlorine because endotoxin will be lifespan very short. So the hemodiafiltration going to same membrane with an infiltrate, and subsequently you can infuse such a volume, very big volume, either pre or post filter, and this is called pre-dilutional or post-dilutional hemodiafiltration. All what you need that to prescribe the hemodiafiltration lines and put the machines in the automatic mode. Again, I don't like the manual mode of hemodiafiltration because it carries a lot of risk to the dialysis circuit, and I think it will not be very nice session if you are using the manual mode. So pre-dilutional, meaning that you inject or infuse the dialyzer by pre-filter substitution, which is around at least 50 liters, and post-dilutional, meaning that you put the such infiltrate substitution in the post-filter mode, and minimum to be 23 liters at least per session. Again, what's the difference between hemodialysis and hemodiafiltration? Augmentation of the solids removed, yes, and larger molecules could be as well removed. So making that very, very successful for treatment of patient uremic status, and subsequently hemodiafiltration remove small solids as any of low flux even, and remove middle molecules much higher than high flux, and remove specifically higher molecular weight like inflammatory cytokines, kappa and lambda light chains are also included in the hemodiafiltration treatment. So what is the mode? We have a pre and post, as well we have a dose, low and high efficient hemodiafiltration. If you are using a low volume hemodiafiltration, it's nonsense because it doesn't add any clinical advantage over the high flux. So if you are going to do hemodiafiltration, you have to check routinely each session the volume of convection and substitution. This is typically the volume at least per session, and this is per square meter. So if you have smaller or younger low weight dialysis patients, you may not reach this huge 25, you can reach 21 per square meter. So in all conditions, you have to manage that. And I wonder that some of the clinics do hemodiafiltration, but if you ask it, what is the dose? No one answers. So it's nothing to do hemodiafiltration without writing specifically per each session the dose and substitution volume applied. So post-dilution hemodiafiltration, meaning ultrafiltration followed by replacement. Pre-dilutional, meaning infusion of replacement fluids in the pre-dialyzers. Mid-dilutions, meaning in the middle, and the mixed you can control, some like 15% pre-dilution and 85% post-dilutional. In some hemodialysis machines has this specific scenario inside the system. I think all of us used the post-dilutional, some indication for pre-dilutional, mainly for the coagulation profile, because you can use pre-dilution without anticoagulation, but you cannot do post-dilution without proper anticoagulation. Second point in the pre-dilution, if the patient is malnourished. If you are using post-dilutional, you may have albumin loss. So I prefer as well the pre-dilutional. So two categories importantly improving that. On the context of the performance, all the literature either equivalent results between both if you reach the goal or in advantage of the post-dilutional one. Consideration in choosing a specific hemodiafiltration, as we said earlier, the pre-dilutional in patients with no anticoagulation or who experienced very high clotting during hemodiafiltration, also in malnourished as albumin loss is minimal with the pre-dilutional, simply because the transmembrane pressure is very low in pre-dilutional and very high in post-dilutional. So the pre and post differences. In the pre, you dilute more of the blood, you reduce fiber clotting, prolonged filter life, reduce effective clearance around 15% because what's passing inside the filter is fluids and the blood. More replacement solutions are required, at least double the volume in post-dilutional therapy, and increasing the QP to overcome the reduction in clearance. However, in post-dilutional, no reduction of clearance, less replacement solution are required, increased need of anticoagulants, limits on UF rates due to hemo concentration and protein concentration as well, protocrete. So technical and the clinical, what is the barrier to achieve that? Mainly inside the, to my opinion, the major barrier is the vascular access. You have to reach a very high blood flow, at least 350 to reach the goal of that. If you cannot reach, you have to expand the dialysis time. So you can do hemodiafiltration. If the vascular access is not reaching 350, you can extend the dialysis session to 5 hours to reach the target of substitution volume of at least 23 liters. So this is a convection that leads to a very thick protein deposit on the membrane induced, and this is called the protein fouling. Increased viscosity of blood inside the dialyzer with a progressive increase in end-to-end pressure drop and pre-dialysis pressure. You can find even rupture of the blood tubing before the going to the dialyzer if the pressure is high, and thanks again to the feedback control of the dialysis machines. Hemodialysis machines are variable. All of them have a specific feedback control. Importantly, what is called the increasing in the progressive transmembrane pressure, the machine can do 2 steps. One step is to stop ultrafiltration. Second step to do by itself, back filtration. So it cleans the dialyzer, filters and membranes from outside to inside. And this happens automatically. You are not aware about that. Once the transmembrane pressure exceeding a risk and cannot achieve the target or the goal of ultrafiltration, automatically the machine stops ultrafiltration and do back filtration. Another blood flow inside the filter is reduced by the machine and with substitution directly in the bloodstream side. So it's called infusate of the saline or the dilate around 100 milli of saline just to wash out of the protein absorbed on the dialysis membrane. This is the major 2 steps in the biofeedback in the machines. This is controlling the pressure, and the machine feedback control is controlling by the transmembrane pressure and ultrafiltration. If it goes very high, we have to stop the ultrafiltration and doing automatic back filtration and or IV injection of the dialysate in the bloodstream going to the filter to clean up that. This is importantly and this subconsciously. If you are doing that automated, you are in the safe side. But if you are using hemodiafiltration in the manual mode, some blocks this feedback control, and subsequently pressure may go high and failure of the station will happen. So we have back filtration on demand. We all know that what's called back filtration is movement of fluids from the dialysate to the blood side. But here in the new, it's called on demand. So back filtration on demand, meaning the machine feels that failure of ultrafiltration and the higher transmembrane pressure pushing dialysate from the dialysate side into the blood side, making cleaning up the internal lumen of the membranes, subsequently anti-fouling effect. In hemodiafiltration and Shams University, we did a lot of sessions. Basically, the machine should have 2 blood pumps. We are using regularly the filter above 2.0 square meters. And we have to monitor exactly what's happened inside the session, meaning that you have to find your prescription, the substitution, the ultrafiltration goal, the transmembrane pressure, each single. And if the machine feeling that high transmembrane pressure happens, the pump into it directly into the blood by dialysate or inside the filter by a back filtration on demand. So this is the 2 pump, one for the blood flow and one for the substitution flow. And usually in the range of 30% of the blood flow is the second pump. So if you are going to say, blood flow 350 milliliters per minute, you can find the second pump of substitution is around 100 to 120 milliliters per minute. So hemodiafiltration over high flux in Shams University, you can see the difference. We have very high beta 2 microglobulin reduction ratio, reaching 82% at least in sessions. For urea, it doesn't differ too much because it's a very small solid. However, larger solid is important. You can look to this graph as well. If you are using small dialyzer, you can find the increase in transmembrane pressure during the session, nearly the double. But if you're increasing the surface area, the transmembrane pressure is not the doubling, but less than in the range of the 50% of the starting. One of our studies as well and published is what is the effect of hemodiafiltration on the epigenetic changes and DNA methylation. And you can find very interestingly that the hemodiafiltration and the epigenetic changes are importantly available, but depending on the dose. So the epigenetic changes and DNA methylation is importantly and improved if you are reaching the high substitution volume. Subsequently, 23 liters is considered as the minimum. But for the protein, uremic toxin linked to protein, uremic toxin, like many of them are protein linked. So there is bicresol and inositol, all of them are hardly even removed by hemodiafiltration. And this is the space why we have to always reserve and preserve the residual kidney function. Even if the GFR is 5 milliliters per minute, keep it as it, because it removes protein bound uremic toxin. No one of the hemodialysis up till now can remove this specific fraction of uremic toxin, which is the protein bound toxins. So this is the dose dependent in our studies. Seems that with higher substitution, there is marvelous response of the DNA methylations and the epigenetic changes. Decision relating factors. When to start hemodiafiltration, you have to put the patient selection. If the patient is not well with high flux dialysis, you cannot jump from low flux to hemodiafiltration. You have to put a step of high flux. If high flux does not improve the patient, you go directly to hemodiafiltration. If you need a high convection, special clinical situation, you need an online hemodiafiltration machine, equipment, dialyzers, infusion line, water treatment, and you have to prescribe the infusion volume. So this is the strategy when you are implementing a new hemodiafiltration protocol inside your center. You have to define the equipment, the lines, the dialyzer. Not all dialyzer or not all high flux are usable in hemodiafiltration, and this comes later in the end of this talk, which dialyzer is best for hemodiafiltration. So